I'm going to introduce our second speaker, who is none other than Dr. Suresh Paranjoti. Dr. Suresh is one of our cardiothoracic anesthetists in the same department as me at National University Hospital. And he completed his specialty training in anesthesia in the United Kingdom and Canada. And he has interest in e-learning, medical education, and point-of-care ultrasound. And today he's going to talk to us about focus applications for anesthetists. Suresh, over to you.
Thanks, Terry, and thank you to the college for inviting me to give this presentation. I'll be talking about point-of-care ultrasound and applications for anesthetists. Essentially, as anesthetists, we're quite accustomed to using ultrasound, especially for procedural purposes. I won't really be talking about that in this presentation, but I'll be focusing more on the diagnostic applications of ultrasound. So what is point-of-care ultrasound? It's essentially an ultrasound examination performed at the bedside by the treating clinician. It's usually a quick examination performed as a focus study, either to rule in or rule out pathology, and it can quite often expedite or change management decisions. Just to wake everyone up after lunch, here's an example. This was a case in NUH about 5 years ago, where the patient had a cardiac arrest on table during a cesarean section, and as you can see, we managed to make a diagnosis quite quickly within 5 minutes. You can see clot within the IVC and clot in the right ventricle as well. So it can be useful in emergencies. Okay, so there's been quite significant growth in the past decade or so with regards to point-of-care ultrasound. There's a lot of cheap devices on the market which can be connected to your mobile phone and stuff. There's also incorporation of AI technology, automated ejection fraction calculation, and things like that. Some of these AI methods have been validated as well, and there's more and more of it coming to the surface. There's also been increasing acceptance and an increasing evidence base. If you look at publications regarding POCUS, there's been quite an exponential increase, and a lot of those publications have been in the past 4 years. So what about the evidence? As you can see, diagnostic accuracy is quite high for POCUS applications. The ones in the box are probably more relevant to anesthetists. POCUS, airway POCUS, lung POCUS, cardiac POCUS, and FAST for trauma. Other causes for the increase in the past couple of years have been the COVID-19 pandemic, and obviously POCUS can also lead to significant cost savings for the patient, and also reduce radiation and unnecessary investigations. So we can look at diagnostic accuracy. Although many of the studies published have shown high diagnostic accuracy for POCUS, we do have to keep in mind that it's an operator-dependent investigation. There can be patient factors as well, which can make performing POCUS difficult, and obviously the environment or situation. Sometimes it can be quite difficult to perform a scan in the operating room, especially with drapes and surgical equipment on the patient. So there are harms and risks. Thermal effects and cavitation, they're quite rare, not really significant. Cross transmission of pathogens, but that can happen with the stethoscope as well. Maintenance of machines and probes, this is quite important. Obviously the ones that we fear the most are probably misdiagnosis, wrong diagnosis, or overdiagnosis. but it's kind of a bit reassuring to have a look at this publication. This was done in emergency medical physicians. I'm not sure if it applies to anesthetists, but they essentially found that the lawsuits were more related to failure to perform a scan or delay in performing a scan, as opposed to misdiagnosis. So there is potential to cause harm. So you can look at some risk mitigation strategies and challenges to risk mitigation. Training can be an issue. Lack of educational experts is frequently cited, and lack of standardized educational curriculum as well. Lack of structured training during residency. Image storage can be a huge problem as well. A lot of the machines used for POCUS are handheld, and they require Wi-Fi connection to the hospital in order to get images stored onto the PAC system, and this can be an issue as well. It's also important to have quality assurance systems in place when we have a point of care ultrasound program in our hospitals. We may need to seek advice from the radiologists or cardiologists to help us with quality assurance and credentialing and certification systems. These can be either institutional or national. Okay, let's look at some specialty specific guidelines. Essentially, emergency medicine have been leaders in this. Guidelines from emergency medicine first came out in 2001, and they have basically incorporated POCUS into their residency training. It's a core component of their residency training. This is not just in America, but also in Singapore as well, where POCUS forms a key component of emergency medicine residency, and it's been in place since 2013. Same for critical care medicine as well. They have had specialty specific guidelines in place since since about 2015 or so, and they are exams specifically for POCUS in critical care. Anesthesia, on the other hand, has been a bit slow. This is a survey done in 2018 in the United States, which showed that only 36% or so of respondents had structured POCUS training. There are, however, guidelines which have been recently published by the American Society of Regional Anaesthetists. These came out in 2021, just last year, and they've basically defined the core components that anesthetists should gain competency in. These are airway, lung, cardiac, gastric, and FAST. Okay, they've also recommended a standardized framework for POCUS, and they've given recommendations for minimum training requirements. So some of the barriers that are often cited to implementing POCUS in our practice include lack of equipment, lack of standardized curriculum, and lack of sufficient qualified faculty. Time is also a big problem. There's often lack of time to kind of implement a structured program into residency training. So we can look at some protocols for different clinical situations. There are so many protocols described in the literature, it can be quite confusing. This is just a small number of them. So instead of using protocols, we can also use an organ specific method, or we could also use this method, which is the IAIM method, which basically recommends using this framework when we apply POCUS in our practice. So the IAIM framework basically involves looking at the indications, acquisition, interpretation, and medical decision making. And this can be used for teaching, learning, assessment, performing, and some have even suggested that it can be used for billing. So in terms of competency, this is a question that frequently comes up. How many scans do I need to do before I'm competent? These are recommendations from ESRA. So it's about 30 to 50 scans for most focus applications. For cardiac, it's a bit more, 100 to 150. But I think there's a big difference between acquisition and interpretation. This is a medical student who had about a 2 hour training session, and this is a acquiring an image about 4 weeks later. So you can see it's probably quite easy to teach acquisition. It's quite easy to learn, easy to assess, and easy to demonstrate competency. Interpretation, however, can be a bit more difficult, can be a bit more time consuming. Involves pattern recognition. It can be difficult to assess competency. There's also the added issue of incorporating findings into medical management, and these things can take time. But having said that, we all learn how to interpret ECGs and chest X-rays in medical school, so why not focus? And indeed, some medical schools have incorporated focus education into their training programs. So we can look at some certification programs. There are certification programs by the American Society of Anesthesiologists, which kind of take the issue of image interpretation as well. They have online case-based diagnostic modules, and I think from the ASA it's about 160 cases. And again, their recommendations for practical skills range from between about 30 to 50 scans. So let's look at airway ultrasound. Some of the indications, there are quite many in the literature, but we'll just concentrate on the first three. Identification of cricothyroid membrane, confirmation of endotracheal tube, and predicting difficult laryngoscopy. So quite a number of studies have shown that it's quite easy to teach acquisition. These studies have involved about a 1 or 2 hour lecture and practical session, and followed by assessment subsequently, and they've shown quite high success rates at both teaching and identification of cricothyroid membrane by ultrasound. And this lower study in 2015 also showed that cricothyroid membrane was only successfully detected by palpation in about 37% of participants, and by ultrasound it was as high as 83%, and this was in a morbidly obese patient. So in terms of scanning the neck for identification of cricothyroid membrane, we can either scan in the transverse plane or sagittal plane. There are two methods described: the Taka method or string of pearls. So the images on the top right here are the airway in the transverse plane, where you can recognize the thyroid cartilage as a V-shaped structure, the cricoid cartilage as a horseshoe structure, and you can see tracheal rings here. Okay, and in the longitudinal or sagittal plane, you can see thyroid cartilage here and cricoid cartilage here and cricothyroid membrane in the middle. The tracheal rings appear as a string of pearls. Okay, in terms of predicting difficult laryngoscopy, quite a number of parameters have been studied. Some examples include tongue width, mentohyoid distance, skin to epiglottis distance, and a few others. This meta-analysis published in Anesthesia and Analgesia in 2022 showed that skin to epiglottis distance was the most studied parameter, But overall, the paper concluded that there wasn't really enough evidence to recommend its use in clinical practice. The studies were mostly quite small, and there was too much of heterogeneity. So same thing, another meta-analysis. This one showed that higher mental distance was the most reliable parameter, but again, small sample size and heterogeneity of studies make it difficult to recommend upper airway ultrasound for difficult tracheal intubation. So in terms of detecting tracheal intubation, quite a number of studies have shown that it's feasible, high accuracy rates. So basically, you get uh, a double line here when the tube is in the trachea. You can see the image on the right here. This is esophageal intubation, where you end up with two lumens side by side when the tube enters the esophagus. Okay, so I'm not recommending that you use ultrasound to confirm tracheal placement in our daily anesthetic practice, but it may be useful in certain states such as cardiac arrest, low cardiac output states, severe bronchospasm, or when there's no access to capnography. Okay, so this is something, I think it's probably a publication from Emergency Medicine, but they've some recommendations as to how you might be able to incorporate POCUS into your airway assessment. So basically looking at the skin to epiglottis distance, marking the cricothyroid membrane before starting anesthesia in a potentially difficult airway. We can also scan the stomach to determine aspiration risk. And post-intubation, we can use ultrasound to determine correct endotracheal tube placement and to verify depth of endotracheal tube placement as well. So looking at lung ultrasound, again, you can use the IAM framework. So lung ultrasound is quite interesting as the lung is an airfield structure, and most of the signs in lung ultrasound are dependent on artifact generation. So you can use either a low frequency probe or high frequency probe for lung ultrasound. The low frequency probe is better for scanning the deeper lung parenchyma, whereas the linear probe is better for the pleural line. Sorry. Okay, in terms of protocols for acquisition, there are a number of protocols described. You can either divide the lung, each hemithorax, into 8 zones or 12 zones, or in an emergency, you can just use six zones on each side of the chest. The blue protocol, which was described by David Lichtenstein, is a French intensivist. So he's been a huge advocate of use of ultrasound in critically unwell patients, lung ultrasound in critically unwell patients. And this is the blue protocol that he's described, which is basically bedside lung ultrasound in emergencies. And if you follow his decision tree, you can more or less diagnose the major causes of dyspnea in patients with quite good sensitivity and specificity. Okay, so let's look at some images. So these are scans of normal lung. So you can see the pleural line here. It has an ants marching sort of appearance. So this is due to lung sliding between the parietal and visceral pleura sliding, and this is called a lung sliding sign. You can see A lines here. These are essentially reverberation artifacts, and they indicate a normally aerated lung. On the right here, you have M mode and what is described as a seashore appearance, and this is seen in normally aerated lung as well. What happens in pneumothorax? You lose lung sliding. You can see here there's the shimmering appearance of the pleura disappears. and the pleura doesn't appear to be moving at all. And if you put M mode across it, you get the barcode appearance. So this is typically seen in pneumothorax, but can also be seen when the lung is not ventilated, as in apnea, bronchial intubation, or secondary to atelectasis. In order to have more definitive diagnosis of pneumothorax, I found this video on Twitter. So essentially, you need to look for the lung point sign, which is, if you can see here on the left of the screen, there's pleural sliding, whereas on the right of the screen, there's no sliding, and this is called the lung point. And this is very specific and sensitive for pneumothorax. Okay, so I think we're kind of running out of time. So just look at focus cardiac ultrasound. Again, quite standard, three windows and five views. Can be useful for rapid evaluation of systolic function, RV function. If you're looking for pericardial fluid or tamponade, gross valvular pathology, and volume states. Just a little bit about what we do in NUH. In our AOCC clinic, we do have access to a portable ultrasound machine, and we do scan patients who have ejection systolic murmur, especially elderly patients where there's a risk of aortic stenosis. Looking at aortic stenosis, this is what aortic stenosis essentially looks like on echo. The top right shows aortic sclerosis, where the valve leaflets are calcified, but they appear to open well. And the one on the left here shows a normal aortic valve, whereas the one on the right shows a heavily calcified aortic valve with very little movement. Okay, I think we just skip that. So looking at gastric ultrasound, I've not personally done any gastric scans, but when you're scanning, we can use perioperative gastric ultrasound to detect a full stomach. May be useful in the emergency situation or in patients where the fasting status is unclear, such as children or patients with dementia, etc. So essentially, the scan is done in the right lateral decubitus position, and you can see what we are looking for is the antrum of the stomach. So these are some appearances of an empty stomach on the top left, the stomach filled with probably some fluid and mixed solid particles. You can measure the circumferential area, and this can give an indication of the volume of stomach contents. The image on the left here shows quite ground glass appearance, which is consistent with mixed solid and fluid contents. Okay, looking at trauma, the FAST protocol has been used for trauma. It's for quite a number of years, more than 2 decades or so. It's quite useful in the trauma patient to determine if they need further investigation, either CT scan or need to be taken to the operating room. These are some images of fluid in the abdomen. So the top left screen we have fluid in Morrison's pouch. This is the liver here and the kidney, and on the bottom screen we have fluid in the left upper quadrant. So what about evaluation of the hypotensive patient? Again, as you can see, quite a large number of protocols that can be used. The rush protocol is quite commonly cited and used. We can use a high map mnemonic. H stands for heart, I for the IVC, M for Morrison's pouch, A for aorta, and P for pneumothorax. And we can so the rush exam essentially involves scanning of the heart, the lungs, the abdomen, and the aorta. Can also use, think of it in terms of pump, tank, and pipes. The pump is the heart, the tank is your fluid status, and the pipes are your large vessels and veins. Okay. So these are just some images of what you might find in a shock patient. This one is a loop of a patient with cardiac tamponade. You can see fluid in the pericardial space here. The heart looks hyperdynamic, and there looks like there's some collapse of the right ventricle as well. This is an example of an atrial myxoma. You see a large mass in the left atrium causing obstruction to inflow, to left ventricular inflow. This is D-shaped left ventricle. It's quite commonly seen in cases where there's elevated right ventricular pressure, and it can be seen in pulmonary embolism as well. This is an example of type A aortic dissection. You have a flap here and a hugely dilated ascending aorta. Okay, and this is an example of hypovolemia, where the left ventricle looks hyperdynamic and the walls seem to be collapsing. Okay, so I think that more or less comes to the end of my presentation. Thank you for inviting me to speak, and hope you